Hello, everyone. Tihana, can you hear us all right? We had a few technical.
Yeah.
So
Hi, good afternoon, everyone.
Yeah. Hi, look, I think we don't know what happened on the first meeting, but we were in a different room. But here we are, and I think the ones that we have, we're going to record it anyway, but with the ones that we have, we're going to just get going. And so we're on time. So just before I started, thank you for joining us this is Dental Chat by Alluro. And this is our first on this year. We run a couple ones of the Dental Chats last year. And we try to keep it very casual. So if you have any questions, please pop it into the chat. And today, Dental Chat with Dr. Tihana in Sydney is about Citrox, and we call it the new generation of antimicrobial. So she's a doctor, senior clinical lecturer and doctor of dental medicine at the University of Sydney. Also coordinates, I think, the discipline of periodontitis. Yes. So if somebody knows about microbials, will be Tihana, right? So yeah, thank you so much for joining us. I'm gonna pass it on to Tihana to talk about a little bit of what is Citrox and what does it do on our mouth and how good it is. But if you have any questions, again, please pop it on the chat. I have the CPD number for the end of the session, so please hang out. And yeah, let's reconnect later. Thank you, Tihana.
Okay, so I will share my screen, and you have to enable me to do so. Okay, thank you, and I will be with you in a second. Okay. So I hope that everybody can see my slides and also clearly hear my voice. Thank you for coming and joining this webinar today, and it's my privilege and also it's nice to see you here. And today I will talk about the new chapter in chemical biofilm control, and I will chat about the Citrox as the new generation of antimicrobials, its potential and promising effects that it showed so far. So basically, before I start, I just would like to remind you on the global burden of disease study from 1990s and until 2010. And unfortunately, that indicates that the periodontal diseases are the sixth and the most prevalent diseases worldwide, unfortunately still, with the prevalence of more than 11% and around 743 million people affected. And unfortunately, this global burden of periodontal diseases is increased by more than 57% in the period of time from 1990s to 2010. And basically, the periodontal disease brings and causes disability because untreated periodontal disease, and also in some situation, even if we're treating periodontal disease but do not maintain our patients, they are most likely they're going to lose their teeth. So depending on the number of teeth lost and the position of those teeth, people are experiencing more or less some sort of disability because they can't masticate their food anymore properly. They also have a problem with aesthetics, with phonetics, and so forth. And also periodontitis is a huge global burden on the economy and economies worldwide. Also, what we have to be aware of is that the prevalence of periodontitis increases with age, not only the prevalence, but the severity of periodontal disease. And you might see with your patients when you're treating them, the elderly patients are more likely to have a severe and more severe periodontal diseases, more teeth loss due to periodontal diseases, and the incidence of the periodontitis deeply rises in adults aged 30, 40 years and more years old. Taking into account that we are aging population, and in the very recent future, we're gonna very near, I would say, future, we have lots of elderly people and more elderly than than younger people. And the aging population not only growing, but also retaining more teeth. So periodontal diseases will remain the issues that we will face on a daily basis in our dental clinics. So currently, more than 57 diseases have been studied regarding with their association with periodontitis. Because many of these systemic diseases and conditions share social determinants and risk factors with periodontal diseases, such as smoking, obesity, poor nutrition, physical inactivity, and also, unfortunately, the effect of periodontitis doesn't stay in the oral cavity, it goes beyond the oral cavity. And we all know that very aggressive bacteria that are causing periodontal disease may reach and get into the bloodstream and also reach distant tissues and organs and also colonize them and cause some damage there. And also we all know that periodontitis is an inflammatory, complex inflammatory disease that can also increase the inflammatory burden of the entire body. So far there are lots of evidence about the association of periodontitis with cardiovascular diseases, usually atherosclerosis, then diabetes mellitus. The association is bidirectional. We all know that with the treatment of periodontitis and controlling periodontitis, the patients with diabetes will be able to better control their blood sugar level. Also, some sort of pulmonary infections, rheumatoid arthritis association with periodontitis is of increased interest in the science, and also certain types of cancer and cognitive impairment, namely Alzheimer's disease, may be also associated with periodontal diseases, namely periodontitis. We also know that our patients that are coming to our dental offices are more interested in getting implants as oral rehabilitation, as dentures, and also even fixed prosthodontic work such as bridges are less popular nowadays. So it is estimated that more than 12 million implants are installed annually. However, unfortunately, implants are also not immune to peri-implant diseases. After the implants are exposed and rehabilitated with the superstructure, biofilm comes and populate the surface usually of the abutment, and if it's not regularly removed, it can cause peri-implant mucositis and peri-implantitis. And peri-implantitis affects each year over 1 million implants, and I think these numbers are increasing. So basically, this is the contemporary model of host microbe interactions in the pathogenesis of periodontitis that's been recently published and also presented at the last Perio conference in overseas in Europe in 2018. And this clearly shows that everything starts with the biofilm. So the biofilm, whenever biofilm is when controlled, we will have a clinical health. So our gums and periodontium will stay healthy. Not only biofilm is a culprit, but also we have to pay attention to different risk factors. So we have several types of risk factors that may contribute to onset and the further progression of periodontal diseases. So those are behavioral risk factors, environmental risk factors. Very common one is smoking, and also some of the patients may be more susceptible to periodontitis. So we have also genetic risk factors that we can't at this stage control, unfortunately. However, once we neglect the oral hygiene and the biofilm becomes mature and exists on the teeth and below the gums for a certain period of time, it will cause a initial inflammation that will affect only gingiva. So that's called the gingivitis. Gingivitis is fully reversible, but only if it's addressed and treated in timely manner. If it's not addressed and treated, after a while, it will cause a further destruction of periodontal tissues. And once we lose the bone and attachment, the periodontitis is irreversible. And the problem is that as a complex disease, it requires complex treatment, and also we can arrest it, but unfortunately we can't reverse the lost tissues. Even though we are now dealing and having very advanced procedures, surgical procedures, regenerative procedures, it's very hard to reverse the process. And also the patients with the periodontitis, once we treat them and achieve some results, we have to keep them under a continuous surveillance and maintenance in order to prevent the recurrence of the disease. Very similar, we have the patients who are rehabilitated with the dental implants. As I mentioned before, same, the implants are not immune to peri-implant diseases. Everything starts as a very mild peri-implant mucositis that also affects only the soft tissues that surrounds the implant and abutment. However, if it's not treated in a timely manner, and if it's left like that, after a while, it will progress further and cause the loss of the bone around the implants and some of the osseointegration, and it will become periimplantitis. Periimplantitis, even though very similar to periodontitis, is more complex. The treatment is also more difficult and complex, and results are unpredictable. So basically, the key is in prevention, and it's sometimes that we as practitioners sometimes neglect, and also our patients, they don't believe in that, so that just a toothbrush and very simple hygiene can keep their teeth and the gums healthy. So modern concept of the mechanical of the biofilm control encompasses mechanical biofilm removal, and it's always number one. When I'm teaching my students, I'll always tell them, always talk about the mechanical plaque control, and only and the patient is not able to maintain their hygiene at the highest level with the mechanical plaque control, we should try to find some other solutions. So the mechanical biofilm control using the toothbrush and the interdental brushes are the foundations of the prevention, and also will enable the patient to adequately and remove the biofilm on a daily basis. However, in certain situations, not all of our patients are able and capable to use a mechanical plaque control effectively. So in that case, in certain indications, perhaps we need to use something else, and we have to use a chemical plaque control. But these chemical plaque control agents works best when are used as adjunct to mechanical plaque control, and in that case they may help to prevent colonization and also alleviate the inflammation of the surrounding tissues. So basically, this is the situation on the market in Australia, and I believe in worldwide as well. So we have lots of oral antiseptics that are commercialized and also sold in different forms. So we know that oral antiseptics can be delivered as and manufactured as gels, sprays, varnishes, toothpaste, and also we have a mouth rinses. Mouth rinses are the most popular within the patients, and also there is a lots of evidence about their efficacy, and they are also more effective than other types of products such as gels, sprays, and so forth. It's very easy to use the mouth rinses, and also they can, due to low viscosity, they can reach all those niches loaded with the biofilm that perhaps the mechanical plaque control or even your instruments can't reach. And that's why the mouth rinses or mouthwashes are the most. Okay, one of the oral antiseptics that's commonly used and that we have a lots of experience with it, and it's still gold standard, is the chlorhexidine. So chlorhexidine, as we all know, has a large molecule, and it has two positive charges. It's a cation, and that actually makes him very reactive. It reacts with other components and substances that are usually negatively charged. Chlorhexidine is not only used in dentistry, it's used in medicine, and also it's in many products for medical purposes and also cosmetic purposes. So it's widely used antiseptic. So in dentistry, it's used in several concentrations. It has a broad antimicrobial spectrum of action, so it is efficient against the gram-positive, also gram-negative microorganisms, bacteria, and also it can suppress Candida species, especially Candida albicans. And we all know when our patients are having a denture stomatitis, very mild forms, we can use chlorhexidine. Most commonly either in a form of mouth rinse or gel, just to treat the denture-induced stomatitis. And if the patients are having a little bit more severe forms of candidiasis, chlorhexidine still can be used as adjunct to the antifungal treatment. So the higher concentrations concentrations of chlorhexidine are usually 0.12%, that is very commonly used in overseas in Europe, and 0.2% that it's commonly used in Australia, I believe in New Zealand, America as well, Canada. So these higher concentrations actually have immediate bactericidal action followed by prolonged bacteriostatic action. At the level of the biofilm or the plaque, these higher concentrations show strong anti-plaque and anti-inflammatory properties. So when we are talking about the mechanism of action, we usually talking about the mechanism of action at the cellular level and at the biofilm level, because we all know that cells, when they're single cell or in their form that is not within the biofilm, they are more vulnerable, and it's very easy to destroy those cells. So they are planktonic forms. They are more fragile and vulnerable. When they are within the biofilm, they are very protected, and also they are less likely to be affected or influenced by any of the oral antiseptics. So they are actually stronger in the community. So if we are looking at the cell level, so chlorhexidine, because it is positively charged, it binds very quickly to the surface of the cell. Cell uptake is just for 20 seconds, and its action is very fast. So basically, the chlorhexidine destabilizes the membrane of the cell and also interferes with osmotic process or osmosis, allowing some substances from the cytoplasm to leak out of the cell, which will destabilize the cell. Also, the chlorhexidine further can cause the larger damage to the membrane, penetrate into the cell, and also allow the cytoplasmic content to leak out of the cells. And that's how the chlorhexidine is killing cells. Higher concentration of chlorhexidine, let's say 4% concentration, then even solidify the cytoplasm of the cell and kill cell that way. So basically, when we see some of the here of bacterial cells, so the black area is the cytoplasm. This is the cell membrane, and these cells were treated and exposed to the chlorhexidine. So very, very rapidly after exposure, we can see some changes that are actually localized around the cell. So we can see some changes that affect the cell membrane. And then here we can see that the cytoplasmic components are leaking out. And here, if we compare the image A with image D, we can see that here cells are empty. So that means that they are not alive anymore and all content is out of the cell after the chlorhexidine. So when we are talking about the lower concentrations, we usually refer to concentrations that are less than 0.1%. So in the world, and here we have concentration of 0.05, 6, and 9. They only have a bacteriostatic action they are not killing. This concentration are able to kill the bacteria, and also at the biofilm level they show only anti-plaque properties, not anti-inflammatory properties. So the mechanism of action is very similar. So even those lower concentrations are binding to the cell surface and also destabilizing the membrane and allowing the leakage of certain components. In this case, potassium and phosphorus would leak out of the cells, and those are very important ions for cell metabolism and development. So at the biofilm level, we can see that chlorhexidine prevents the formation of the plaque. So we know that the prerequisite for formation of the plaque is secondary dental pellicula, which is formed by precipitation of salivary glycoproteins and mucins. So basically, chlorhexidine prevents absorption of the secondary or new acquired pellicula, thus preventing the also attachment of the bacteria. In the same way, chlorhexidine is reducing number of vital bacteria in saliva that are able to colonize the tooth surface. And also, as we can see here, this chlorhexidine binds on the bacterial cells, preventing them from absorption to the enamel and preventing them from coaggregation, which are the process in formation of the biofilm. Chlorhexidine can very slightly penetrate the biofilm, and sometimes it can knock out calcium ions, which is believed to glue and bind the cells, also binds the cells together. when tested chlorhexidine on a mature plaque, it's been shown that efficacy is very low because mature plaque is really protected and due to low penetrating capabilities of chlorhexidine, the chlorhexidine can't do much on the mature biofilm. And that's very important when we are advising our patients to use chlorhexidine products. We have to remove the biofilm and expose the bacteria to the chlorhexidine and increase efficacy of the chlorhexidine by exposing the bacteria. Substantivity is one of the very important characteristics of and features of the chlorhexidine, and its substantivity makes him to be very strong and potent antimicrobial agent. Substantivity is a capability of the substance to bind to the oral structures and to release in the therapeutic concentration over the longer period of time. And the period of time that we actually need is at least up to 12 hours. And the substantivity of chlorhexidine is up to 12 hours. And therefore, when we are suggesting our patient to use chlorhexidine-based mouth rinses, we usually ask them to rinse twice a day for, let's say, up to 60 seconds to provide the adequate dose. Chlorhexidine, even though gold standard, it's not without adverse effects, unfortunately. And we know that one of the most common and most annoying adverse effects, not only for us, but for our patients, it's just the extrinsic yellow-brown discolorations of teeth, oral mucosa, and also tooth-colored restorative materials. And this discoloration even can be intensified by certain diet and presence of biofilm. So when we are advising patients to use chlorhexidine-based products, it's good to tell them to just avoid some of the nutrients such as wine, tea, coffee, also iron supplements, which can make this staining even more potent and more noticeable. Potential to stain increase rapidly when we are using chlorhexidine in concentrations that are higher than 0.1%, and very often when we are using the products for longer period of time, let's say longer than 2 or 3 weeks. Another adverse effect that is not that common of the chlorhexidine is the actually a problem with the salt taste, as chlorhexidine may interfere with the function of taste buds. So basically the salty foods become bland and we don't feel the taste of the food anymore. Luckily, this adverse effect is reversible. So the moment patients stops using the chlorhexidine-based products, it will get back their taste for salt. Chlorhexidine products, especially mouth rinses, can also cause temporary sensation of burning and drying of oral mucosa, which is usually related to mouth rinses that are having alcohol as a part of the solution. Also, desquamative lesions, erosions have been noticed of oral mucosa, of course, but especially when chlorhexidine is maybe used as not as suggested or prescribed more than 2 or 3 times per day, and when it's held in the mouth for a longer period of time, and on the top of it, if it contains alcohol, and also transient swelling of parotid glands also may occur, but it's relatively rare. What about allergic reactions? Allergic reactions are not common; they are very rare, and mostly they are localized. So, but in the recent time, there is it's been noticed that the allergic reactions to chlorhexidine are on the rise, and especially type 1, which can be life-threatening, such as anaphylaxis. So if we take a look at the Australian market, we can identify the TGA approved more than 157 chlorhexidine-based products that are used not only in dentistry, of course, but in cosmetic purposes, in medicine, and so forth. And in the United Kingdom, in the recent time also, especially on the patients who are spending more time in the hospital, who are more in a content in higher concentrations of chlorhexidine, they showed the increasing incidence of the allergic and actually severe allergic reactions. So now many of the companies are trying to reduce the use of chlorhexidine and also to replace the chlorhexidine with other active agents just to minimize these potential and very severe adverse effects. One more adverse effect is a microbial resistance to chlorhexidine. Resistance is more common with antibiotics. That's why we are trying to reduce the use of antibiotics and preserve them only when we really need to use them. We're using them short time and the higher doses in order to avoid the development of microbial resistance. Microbial resistance, when we are talking about antiseptics, is less likely to occur. However, again, in the recent time, some of the bacteria and even oral bacteria and even fungi such as Candida albicans species showed resistance to chlorhexidine and even cross resistance to some of the antibiotics. So basically keeping that in mind, we have to try to find some other solution maybe to avoid these potential problems. And again, we are going back to basic, going back to nature. So over 350,000 plant species are used in the medicine. Are actually there are sorry about that. There are 350,000 plant species, but only 50% of them have been analyzed for their biomedical and biomedicinal purposes. So here I'm showing the citrus fruits. So I hope that we all using them, and when we are having a cold or flu, we're trying to use these fruits in order because they are healthy and have high concentration of the vitamin C. And we all know that scurvy, one of the disease of the past, I must say now, has been treated with the vitamin C. And also these citric fruits have other benefits, health benefits. They may be a remedy for preventing of kidney stones formation. Also, they may play a role in lowering blood pressure, and definitely they can modulate inflammatory process and very popular and are having an outstanding role in new drug discovery. So today I will mention one of these fruits that we are usually not using and not consuming, but it's used as a food product as well, enhancer of the flavor, preservative, and so forth. So those are the bitter orange. So bitter orange is full of bioflavonoids that are phenolic compounds and with the proven pharmacological role and health benefits. So very often the parts of the fruit that we are not using, such as pits, maybe skin, in some cases they contain these phenolic compounds that are having health benefits. So bioflavonoids have been widely recognized to have diverse biological and health promoting effects. So there are lots of in vivo studies, in vitro, and also in epidemiological studies, so that show that they have immunomodulatory effects, anti-inflammatory, and also anti-mutagenic capacity. They are powerful antioxidants that we all know. They can also increase vascular or capillary resistance and protect from atherosclerosis. They support wound healing, and also they show some neuroprotective abilities. So Citrox is a complex of bioflavonoid derived from the pith of the bitter orange. So basically, Citrox contains several bioflavonoids, such as neohesperidin, which is used also as a flavor enhancer with strong anti-inflammatory and antioxidative potential. Then we have adnaringin, which has anti-inflammatory and antioxidative potential that's been shown and confirmed in vivo studies. It also promotes cell proliferation and osteoblastic function. It also can reduce DNA damage and prevent from cancers. The other one is sponsoring, with also various biological activities, which are mainly also anti-cancerogenic. Riofolin has also strong anti-inflammatory effect and in the same time antimicrobial activity. These bioflavonoids are not only very effective against the bacteria, but also against the viruses. That's something that we actually need. So Citrox is patented worldwide and used primarily as an antimicrobial agent. Citrox is used as a sanitizing agent and also used as an antimicrobial or antiseptic agent. So usually pith and pulp of fruits is dried and ground into the powder. Powder is further dissolved in the water and processed further and mixed with some of the natural acids, which are citric malic ascorbic acids. And that's how Citrox is made. It has a powerful antimicrobial, antioxidant, and inflammatory activity. So can see that Citrox does not contain any alcohol. Citric malic ascorbic acids are basically used as preservatives to maintain the shelf life of the product, and also they are balancing the pH or acidity of the product to enable bioflavonoids to work the best that they can, and also they are these acids are binding to some ions that may hamper the activity of bioflavonoids, and that's why they are added to the product of Citrox. So Citrox tested with the different bacteria and oral bacteria as well. They show direct and indirect antibacterial mechanisms of action. So direct, actually, they bind to the cell wall, and very similar to chlorhexidine, they can also destabilize the cell membrane and cause some of the ions, such as potassium, to leak out of the cell. They can also inhibit energy metabolism of a bacterial cells and also hamper supply of the nutrients and metabolites. They can also reduce the pathogenicity of microorganisms by targeting their factor of virulence, toxins, enzymes, and so forth. They can also have indirect action through stimulation of the host response through macrophages. They can also prevent biofilm formation through inhibition of attachment of bacteria and preventing them to form the biofilm, so that Citrox coats the bacteria and prevent them from attaching to the tooth surface and coaggregation with other bacteria. Benefits: it has a broad spectrum of antimicrobial activity, so it is very effective against the gram-positive, negative bacteria, even viruses, and some fungi. It's powerful antioxidant with strong anti-inflammatory properties. That's actually what we need when we are talking about the prevention of periodontal diseases. It may also break down biofilm to reach pathogenic organisms, and in general, it's not hazardous to operators and the environment. Also, it has a high safety profile, as it's not toxic, not carcinogenic, not mutagenic, not allergenic, and not corrosive. That's very important. It's been dermatologically tested and also suitable for use on a sensitive skin. And it's been already provided and approved to be used in personalized healthcare products such as cosmetics, food supplements, skin care, dental care products, and other pharmaceuticals. Other characteristics that are really good, it's that it does not change the flavor of any food or the products. It's odorless, colorless, and also it is effective even in the presence of organic material, which is very good for all application. We all know that chlorhexidine is very unstable, and in contact with the pus or blood, it gets deactivated, so it's not active anymore. So this is a very good thing about the Citrox, that it still remains active in such environment. So we have several in vitro studies that tested Citrox on its own. One of the most known studies and mentioned and published in the British Dental Journal in 2011 is a study that tested different formulations of Citrox, so-called Citrox BC and Citrox MDC. So Citrox MDC is most commonly used in sanitizing products, and Citrox BC 30 actually is citrus with mixed with the acids, malic acid, citric acid, and ascorbic acid. So what they tested their efficacy on various microorganisms, aerobic and anaerobic oral microorganisms, and candida species. And what they found actually that Citrux BC, when the bacteria are in planktonic forms, the Citrux BC30 was more active and efficient as compared to Citrux MDC formulation. And Citrux BC30 inhibited the growth of each microorganism at concentration of between 1 to 2%. Also, they tested the same Citrux solutions and formulations on the biofilm, because as we said, the biofilm is quite challenging, and especially as it has protective role in bacteria, preventing diffusion of the bacteria, and also increasing lowering their susceptibility to chemical plaque control. And also it may lower their activity status, and that means that they are less likely to be killed or affected by the antiseptics. So in the same manner, they tested two formulations, and the same also the study demonstrated that working concentration of Citrux 1 to 2% of Citrux BC30 was effective inhibiting the growth of a range of bacteria and candida species when cultured in either broth suspension or a biofilm. So that's how there is actually, we got idea to combine the Citrux with chlorhexidine and to try and test it with different concentrations, higher and also the lower concentrations of the chlorhexidine, in order to reduce adverse effects of chlorhexidine by reducing its concentration. Also to reduce the use of alcohol. We know that some of the products with chlorhexidines are still using alcohol and containing alcohol, and to prevent microbial resistance by aiming different targets in microbial cells. As we've seen, that Citrux can target some different mechanisms as compared to chlorhexidine, and also to increase potential of antibacterial or antimicrobial activity of the chlorhexidine. So we have several also studies that tested some of these commercial products, such as chlorhexidine with 0.2% chlorhexidine with Citrux, which is Perio Plus, and compared with chlorhexidine on its own without any additives, and Citrux on its own. So the microorganisms being tested are some of aerobic and some of the anaerobic microorganisms. And basically, when they compared all these products and also negative control, they noticed that chlorhexidine 0.2% with Citrux was the most effective against some of the bacteria. They also grew these bacteria into biofilms and tested the same products, and also these same products, chlorhexidine with the Citrux, show the highest antimicrobial activity. So more specific study being run by Skulan and published just recently, just last year. What they did, that actually formed two types of biofilms. We all know that caries is one disease and periodontitis is another disease. And the bacteria that are causing a caries are quite different than the bacteria that are causing a periodontal disease. So cariogenic biofilm, those bacteria usually use carbohydrates, and they also produce extracellular polysaccharides to bind them even more to the tooth surface. And also they like acidic environment, as opposed to the periodontal biofilm bacteria that are mostly gram-negative anaerobes or facultative anaerobes. They don't use carbohydrates. They prefer a neutral environment, not acidic, and they don't produce extracellular polysaccharides. And these biofilms usually loosely adhered biofilm and contains most of these periopathogens that can be very dangerous. So this study tested almost, I think, all options with the combination chlorhexidine and Citrux. So a lower concentration of Citrux, such as 0.09, and the higher concentrations, 0.12 and 0.2. And also they tested Perio Plus Focus, that's a gel, which has a concentration of the chlorhexidine of 0.5 in combination and combined with the Citrox, and also they tested against the positive controls. So those were the chlorhexidine with various concentration, but with no additives such as Citrox. So they tested their efficiency on the formation of karyogenic and periodontal biofilms, and also their potential activity on established karyogenic and periodontal biofilms. I just don't want to go into the details of the study. I just want to quote their conclusion. So they said that concluded that chlorhexidine formulation with Citrox were as or more active as the same concentrated chlorhexidine without any additives. And it's been concluded also that Citrox seems to augment the anti-biofilm properties of chlorhexidine with regards to biofilm formation. This is a study that has been not published as yet. This manuscript is in preparation. This is a study that we actually run. So previous studies showed promising results regarding the inhibition of plaque formation of the combination chlorhexidine and Citrox, but they did not say anything about the adverse effects, especially brown staining or discoloration of teeth, and also direct restorations. So we wanted to check in vitro this phenomenon, and wanted to check whether really this chlorhexidine combined with the Citrox can stain in new formula. Perio Plus can stain maybe less than the regular formulations with the chlorhexidine. So we had several test solutions. So we test solutions were Perio Plus with a higher and lower concentration, and positive control was the chlorhexidine as a Savacol that's most commonly used, and ADA recognized chlorhexidine mouth rinse, and as a control we used the distilled water. So we made discs of 8 millimeters diameter and of the same uniform thickness, and we've made 4 discs and used 4 discs in each batch, so we could average the readings. We simulated mouth rinsing with agitation, and as we usually recommend the patient to use the product twice a day for 1 minute, we agitated and rinsed the discs for 2 minutes daily. We used the digital spectrophotometer Vita Easy Shade to measure the discoloration and the change of the shade during the period of time. So we did the measurements at day 7, 14, 21, and 28 days. So in general, that's the period of time that we usually using in mouth rinses when we need it. 2 weeks after some surgical procedures, we are advising patients to use maybe for longer, 4 or even 6 weeks. And I can show you, I'm showing here, this is a Fuji 9. Actually, we tested direct aesthetic restorative materials, glass ionomers, 2 types, Fuji 9 and Filtex Supreme of the same shade. It was a A2 shade. And also we tested the Gradia, as was a composite resin material. So here we see the Fuji 9 and its behavior after the rinsing with the Savacol. So basically you can see this is non-polished or non-polished surface. This is a polished surface, and we can see this weird bluish or greenish discoloration. So it doesn't actually happen in the mouth, in the oral cavity, but still can see that as compared to Perio Plus, there is no any visible discoloration. So just to summarize the conclusions and the results of the study. So final discoloration of the tested materials at 28 days. So regarding the material, the greatest discoloration was noticed with the Fuji 9, followed by Filtec, and then followed by Gradia, and discoloration was statistically significant. And also regarding the mouth rinses, Savacol caused the greatest discoloration, followed by Perio Plus with the 0.2% of chlorhexidine, and Perio Plus with the 0.9% of chlorhexidine. Interestingly, when compared Perio Plus with 0.2 and Perio Plus with 0.09%, they result in statistically similar discoloration values. So now this study is also one of in a row of in vitro studies, which based on one in vitro study, we can't say that Perio Plus is discolorating and causing less discoloration than any other product with chlorhexidine. However, I think this is a good study to show that there is a promising effect, and perhaps when tested in vivo on patients in clinical studies, perhaps Perio Plus has potential to stain less and reduce the staining or that would happen when chlorhexidine is not combined with, let's say, Citrox. So just to summarize everything, Citrox as a natural product showed potential to be used as an active component of a new generation of oral healthcare products, either as a monosubstance or in combination with other active substances that have been shown to be efficient, such as chlorhexidine in Perio Plus line of products. There are in vitro studies which have demonstrated that Perio Plus has strong antimicrobial potential on planktonic forms of oral microorganisms, as well as ability to suppress microorganisms even in biofilms. But we still need in vivo studies. That's our next step to confirm capacity of these mouth rinses for prevention of caries, periodontal, peri-implant diseases, and also their capacity to promote the healing following surgical procedures. So we still need some of the clinical studies, but what I can say, these products are promising, and if we don't use them, we won't know how they act and also whether they have less and causing less of adverse effects. Thank you for your kind attention, and I will be ready to answer any questions that you may have. Thank you.
Thank you so much, Tihana. We're just gonna do a quick presentation of the actual product of Perio Plus. If I can introduce Eric, if you can hear me, Eric, and then just hello.
Here I am.
Yeah, hi, Eric. How are you?
I'm good, thank you, Rudy. Thank you, Tihana. That was a very
Hi, Eric. How are you?
Beautiful, beautiful presentation. Thank you.
Thank you.
Well, if you want to move on to just the presentation of the products, I'll just quickly introduce myself. So my name's Eric Lanius. I'm Managing Director of Cureprox Australia and Cureprox New Zealand. And we are, just also for everybody's information, we were in ownership of Curecept. That ownership has and the partnership has ceased last year. And so Cureprox decided to open up their own subsidiaries in New Zealand and Australia. And so Curecept and Cureprox are now no longer one company. And so Perio Plus was introduced as an improvement from a taste point of view, and overall also in the introduction of Citrox. And so Cureprox and Perio Plus are that's the partnership that we now have. And yeah, so that's just a little bit of background for your information. And so we're trying to introduce this product in Australia and New Zealand. We have so already done in 72 other countries around the world, and with very positive feedback. And one of the biggest the tried and tested attributes and feedbacks that we got were that it was the taste of the solution was actually a lot better than what there was on the market at present. So working together with a Swiss taste company, Givaudan, we managed to introduce a taste that was a lot more pleasant, and the idea was to increase patient compliance. Because a chlorhexidine, as we all know, is an absolute, it takes a lot of courage sometimes if you know what it tastes like in its pure form, and just to go through your treatment twice a day. And so we worked very hard on making the solution taste better, but also making it a very effective anti-plaque agent in daily use. Okay, and yeah, so the ingredients that we also have in there is xylitol. We have no alcohol, and the polylysine, of course, and the Citrox that Tihana spoke about in detail. And in Australia and New Zealand, the name is also different to some other countries. So Perio Plus Regenerate, which you might have seen or heard of or on different websites, is known as Perio Plus Support in Australia and New Zealand. So that's the blue little bottle, or turquoise if you want, and that's the 0.09% chlorhexidine solution. So we have started with in Australia and New Zealand with 0.2, which is Perio Plus Forte, and 0.09%, which is Perio Plus Support. And we've also brought in the gel at 0.5% for a more concentrated treatment on a specific area, on a local area. And also which has now also in this year landed, is the Perio Plus Support toothpaste. So the Fort and the Support are both also available in larger bottles in 900 ml, but the standard is the 200 ml bottle for patient size or treatment size. Yeah, so there is a recommendation for how long you should be using a chlorhexidine solution. The Perio Plus Fort is 5 to 7 days, and the Perio Plus Support is for up to 4 weeks. So yeah, those are pretty much the products that we've decided to introduce into Australia and New Zealand. And yeah, I don't know if there are any questions in regards to support or Fort and further ingredients. We've got a treatment plan that we can send out as well, a patient treatment plan where everything's very detailed.
I have a couple of questions here.
Yeah.
That maybe either Yurik or Tihana can help us. So, I mean, obviously it was quite depth there on the Citrox, and it was interesting, I think I heard correctly, Tihana, that the chlorhexidine stops working when it touched the blood. Is that right? And the Citrox still doing the action.
Yeah, that's one thing that is very interesting, because chlorhexidine interacts also with the sodium lauryl sulfate from the toothpaste. And when we are advising patients to use the chlorhexidine, let's say mouth rinses, we usually ask them to rinse them out before they, after they brush the teeth with the toothpaste, just to rinse them out thoroughly to get rid of SLS from the toothpaste, and then to use chlorhexidine. If they are doing some of the patients there with the high caries risk, they don't rinse their mouth after they brushing their teeth with the fluoride and SLS containing toothpaste. In that case, they have to wait for at least 30 minutes, even to 1 hour, to get rid of SLS in order to use a chlorhexidine. So either to rinse them out thoroughly or to use a gel pastes. They don't contain actually SLS. Otherwise, yes, chlorhexidine is very reactive molecule because it has a double positive charge. Right. And it's always tricky to combine it, even with some other products.
One question as well that I get all the time from customers is when you you rinse it at night is common, but when you rinse it in the morning, so you kind of wait. How long you wait before you can actually have coffee? Or I mean, I don't know if it's a silly question, but it's just about.
Coffee can also, smoking, as I shown, wine, consumption of wine actually can increase the staining.
So
it can't deactivate the chlorhexidine, but may increase the staining potential. But again, we still don't know much about the staining potential. There are some theories and mechanisms proposed, but still it is individual.
And so that means that if you're on the 7 days on the high concentration, you best not to do any of those things.
It's best to avoid those.
Gotcha. And now I don't know if this is for Eric, but is there any reason why the Forte doesn't have the hyaluronic acid and the cyclodentix?
Yeah, so the reason or the decision to not include the hyaluronic acid in Perio Plus Forte was that the gold standard 0.2% chlorhexidine, as widely used worldwide, has basically a place in the doctor's or the patient's mind. And that is something where we didn't want to change or rock the boat too much, where we just wanted a solution that also included Citrox, of course, and that tasted better, but not to change any or diverge too much from the original formulations, even of competitors. So the 0.09, the support is then, and there's different variants as well, but we don't have those in Australia and New Zealand yet. But the support, for example, that you can use for a longer period of time, and also with the hyaluronic acid, which actually, is contained in our saliva anyways, but it's just an added dose of hyaluronic acid to help the healing process. So both have a specific use and purpose, and the Perio Plus Forte, to answer your question, is just not to rock the boat too much and give people what they're used to at first, and then try and wean them off the chlorhexidine over a longer period of time.
Gotcha.
So,
and the toothpaste as a support, is that a combination so you get the best out of the rinse, or can you use just the toothpaste by itself?
Yeah, so like Tihana said, there are SLS toothpastes out there, and that reacts negatively, or it does not benefit the use of, or it's not good using SLS toothpaste or during the chlorhexidine treatment. So that's why the toothpaste, the chlorhexidine toothpaste, should go hand in hand with that when treating someone, so that you don't minimize the effect of the chlorhexidine and Citrox. Yeah.
Right, excellent. The other last question is, what if somebody decided to just use the low concentration? Would that affect the total outcome? Is this if it has to be a prescription where, let's say, it's sell over the counter, so I'm just coming to have a top up. So is it safer to just stock the low concentration, or is it better to always be prescribed? I don't know if this is for Tihana.
Yeah, I'll try to answer that question. So basically, we have to be followed by our patient needs. So the patients should consult the dental practitioners about the use of any chemicals, because there are lots of, as I said, on the market, and usually we don't have evidence for all of them, and we don't know whether they're working or not working. And also, with regards to Perio Plus products, maybe Perio Plus gel is more suitable to be used for certain indications. Let's say I'm using that when I'm treating my patients who are having a peri-implant mucositis, peri-implantitis, but let's say if the patient's having periodontal disease, in that case I'm go mostly for Perio Plus. Okay, depending, let's say if the patient is in active treatment phase, I would go, and if needs chlorhexidine, in that case I would go for higher concentration and a shorter period of time. But let's say after the surgery, I would probably recommend maybe 0.2 for week or two, and then maybe continue with the 0.09% with hyaluronic acid, which will increase and actually support the healing as well. So it depends on indication and individual needs of our patients.
Fair enough. All right. Well, let me just see if there's any other questions from the guys. But it seems that can clinicians extend the use if the results are 50% satisfactory? So if they're working kind of halfway through, can they still use in the Perio Plus, or how long they need to, if they need to pause, how long would that be?
So in general, continuously, whenever I'm suggesting my patients to use any of these chemical agents, this depending with chlorhexidine or any other, usually not longer than 6 weeks 4 weeks, 6 weeks, depending again on the lower concentration are safe to use even for a couple of months. But if the patient really likes using it, I usually tell them, okay, just make a break. If you use, let's say for 1 month, then make a break another one and then continue again. But still, we have to monitor our patients. So it's not fair to tell them, okay, just use the mouth rinse or gel and see you in the next 2 years, because many of the diseases, especially if the patient has high susceptibility, they have to be monitored, especially the periodontitis. I see my periodontitis patients at least once a year, every 6 months. And then I revise whatever they're using. They're using the mechanical plaque control, maybe their interdental spaces are now larger because they don't have inflammation. So I need to change their interdental brushes size from smaller into larger, and maybe they don't need chemical plaque control. But in certain situations, I say to them, look, there is inflammation. Your mechanical plaque control is not quite well, and let's add some of the chemicals. And I gave them, actually suggest them and give a little prescription on how to use it, because usually sometimes they overuse it, which is not good. Also, it will increase the staining. It can increase the potential for adverse effects, and you can make more harm than benefit.
But I mean, regardless of staining, because the staining you can always get it back. But
yes.
You use the chlorhexidine for too long, your gums actually start kind of like.
Yeah, they can get some ulcerations. It was most commonly earlier when the mouth rinses contained a higher concentration of alcohol. So some of the mouth rinses with essential oils, let's say they contain 20% or more than 20% of alcohol, and it's dangerous if the patient is holding them in the mouth for 15 minutes every day or even more, and it can cause even some precancerogenic lesions as well. So it's always important to follow the instructions. And in Australia, in Europe as well, so chlorhexidine-based mouth rinses, they can be just suggested and advised. So they are available over the counter. But in America, I think even in Canada, they need to prescribe them. So you can't buy it.
Interesting.
Yeah. So we have to be careful with that. Even though this product is more natural, there is no alcohol. That means that all these adverse effects are diminished. Still, we have to be careful and consult with the dental practitioners.
Gotcha. Right. Well, we passed over the hour, but thank you so much. Look, unfortunately, we didn't have any attendees, but we will we're recording this and we allow it to have a certain time, not forever, and then we follow up, with some questions and stuff. But thank you so much for joining us from across the ditch.